So I'd like to welcome everyone to our town hall. Typically, we do this in the afternoon, so instead today we're going to have a nice relaxed evening discussion with our guests who we're quite happy to have join us. Dr. Ben Lebwohl is a practicing gastroenterologist. He's the director of clinical research at the Celiac Disease Center at Columbia. He is a member of the Beyond Celiac Scientific Advisory Board and is also currently president of the Society for the Study of Celiac Disease, which he is going to talk about a little bit. So welcome, Ben. We're also joined by Dr. Ritu Verma, who is a pediatric gastroenterologist. She's the medical director at the University of Chicago Celiac Center, and she is a member of the Beyond Celiac Board of Directors and is the president-elect of the Society for the Study of Celiac Disease. And if you're wondering why I keep mentioning that, part of the reason is that Ben and Ritu are going to tell you a little bit about that organization, just in case you're not familiar with it, or the work that they do to benefit the patient community. And they have a specific way that they do that. And so, Ben, I'll let you take over from here.
Thank you, Amy. Thank you, Beyond Celiac. And thank you, Ritu, for joining me on this town hall. As Amy said, I'm the president and Ritu is the president-elect of this society. We're a scientific society. We are for medical, scientific, and allied health professionals who are in the field of celiac disease. Shown here is our mission. It's to advance the fields of celiac disease and gluten-related disorders by fostering research and by promoting excellence in clinical care, including diagnosis, treatment, and treatment patients with these conditions. We have a number of activities. We are a young but growing organization. We have a webinar series really focused on clinical trials, on all aspects of clinical trials in celiac disease. And that is actually free to the public. And you can watch some of those pre-recorded webinars on our site, the celiacsociety.org. We also have quarterly webinars that are live, and those are for members only. Our next one is coming later this month, where we'll be discussing the best of Sorrento, where the recent International Celiac Disease Symposium was held. We have funded travel awards for trainees and young investigators so as to help defray the cost of presenting their original research at various meetings. And we have various grant opportunities. Actually, most recently, thanks to the support of Beyond Celiac, we adjudicated and awarded with the administration and funding by Beyond Celiac an early investigator award, a career development award to really help nurture the pipeline in the celiac disease community. That's just a brief overview of our organization. We're basically all volunteers that, in terms of the leadership, it's just a great way for us to spend our time and learn from each other, and also really help advance the science of celiac disease and grow our health professional community. With that, I'm going to be talking about genetic testing for celiac disease. Amy, should I go straight into that? Is that our plan?
Sure, I think that works. Aside from introducing our audience to the Society for the Study of Celiac Disease, otherwise known as SSCD, both Ben and Ritu are going to address two topics. Ben will talk about genetic testing and in particular, some newer things that we are learning about genetic testing. And Ritu is going to talk about the biopsy and the role of the biopsy in diagnosis. And we'll cover that topic pretty broadly. So Ben, if you want to start by talking about genetic testing, go right ahead.
Great. This is going to be an overview of the sort of established science, what we know about the genetics of celiac disease, how that knowledge is used in practice today, and how maybe it could be changing now and in the near future in light of some recent research. So we know that celiac disease is in part genetically determined, and by that, I mean there is a certain gene type that is necessary for the development of celiac disease. It is a type of the human leukocyte antigen, the HLA. We all have HLA genes. It is a critical component of our immune system, but everyone has a different set of HLA genes, and we inherit them from our parents. And depending on where you are throughout the world and what one's ethnic background is, genetic ancestry, one's HLA types will be different. There are two types of HLA that are very common, that are necessary for the development of celiac disease. That is to say, without those genes, it's really close to impossible for celiac disease to develop. They're called DQ2 and DQ8. They are very common genes. They are present in 40% of individuals in many general populations, including the United States. But the reason this is a useful thing to know in terms of testing is that they are present in virtually 100% of people with celiac disease. Not only is that has this been observed, we also know why this is the case. Shown on the right is a diagram of actually how we think gluten is introduced to the immune system in a bad way. In other words, how it can lead to intestinal damage in people with celiac disease. Shown on the top is gluten, and then it is in the tube, the lumen of the gastrointestinal tract, little bits of it, alpha gliadin, that's one of the fractions of gluten. It then gets presented by certain kind of cells in the immune system. APC stands for an antigen-presenting cell. And the way it presents gluten to our immune system, to various cells, including the CD4 T cell, is it fits in the groove of the HLA DQ2 or DQ8. People with other HLA types, those grooves don't fit those gluten fragments the way a lock would fit a key. And that's why we believe you need to have those kind of HLA types in order to develop celiac disease. The reference here in the lower right-hand corner, by the way, was a fantastic overview on the genetics of celiac disease, written by a group at the University of Chicago, Dr. Verma's home base. Now, I sort of hedged a little bit. I said virtually 100%, and you can see there was this little asterisk present in 100% of people with celiac disease, asterisk. So why? Well, in medicine, often when we say 100%, it's not quite that. It's pretty close. There are rare exceptions. So first of all, one not so rare exception is people who get tested and the test result is read as negative for a celiac gene, but the test didn't actually evaluate entirely for all of DQ2 or all of DQ8. There's a specific kind of HLA DQ2 known as HLA DQ2.2, which is compatible with celiac disease. About 5% of people with celiac disease have that type. And some labs, unfortunately, would call that negative. In fact, one prominent at-home testing lab calls this negative. More on that in a moment. There's also another HLA type called DQ7, which we're starting to recognize may be compatible with celiac disease in a small subset of people. So, I know this sounds like I'm hedging here, but ultimately that's the nature of medicine. We believe that virtually 100% of people have these genes, but there have been exceptions documented, and particularly you need to pay attention to the fine print of the lab that's reporting it. Ultimately, we say testing negative for DQ2 and DQ8 makes celiac disease extremely unlikely. Okay, not ruled out 100%, but extremely unlikely. I should say one can have DQ2 and DQ8. You can inherit both of those. You can inherit 2 copies of DQ2, or you can inherit 2 copies of DQ8. Now, 23andMe is a prominent home testing direct-to-consumer ancestry service, and they also provide information on health risk. That includes celiac risks, and they test for DQ 2.5 and DQ 8, but does not test for DQ 2.2, as I mentioned, and that has to do with the, shall we say, the resolution of the way that they do the genetic testing. So what that means essentially is a negative test is not the same as a negative test would mean if you were getting it in a commercial lab that your physician orders, because it doesn't include 2.2. Now, so if it's negative, you can't be sure that you can't get celiac disease. And also the positive predictive value for a genetic test like this or done anywhere is poor. What do I mean by that? If you have a genetic marker for celiac disease, that does not mean that you probably have celiac disease. 40% of us have this genetic marker, and only 1% of us have celiac disease. So we really generally use genetic testing to rule out celiac disease, because celiac disease is determined by more than the genes. So it's really a combination of genetics and environment. When I was studying epidemiology, I found in my training, I found this rubric to be very helpful. It's called causal pies. It reminds me of, that old board game, Trivial Pursuit, where you would, have to fill in your pie, and then only then would you win the game. So chronic conditions can have multiple causes. And there's this model that I think fits celiac disease well, where you need to have certain components. So there are multiple ways to develop celiac disease, and that's demonstrated by these 3 pies. But all 3 of them have a DQ2 or DQ8. In other words, that is a necessary step. You need to have that. The other thing that's necessary, of course, is some exposure to gluten at some point. Someone who never has gluten in their whole life would not develop the celiac lesion, right? They wouldn't develop the antibody elevation. They wouldn't develop the intestinal damage. And then there are those other factors, and they're shown by those letters, D, C, F, E, J, C. Those could be many different environmental risk factors. And in prior lectures or town halls, or in future, you may be hearing about various risk factors for celiac disease, whether it's cesarean section, whether it's the timing of gluten introduction, various risk factors, none of which are very strong, but they have been reported in various cases. And so causal pies explain why not everyone with the genetic makeup develops celiac disease, because you need more than just the genes. You need to have some of those other components. But causal pies also explain why not everyone with certain risk factors develops celiac disease. So you need to have more than just those environmental risk factors. You need to have some of them in combination, and you need to have gluten, and you need to have DQ2 or DQ8. So genetic testing is primarily used to rule out celiac disease. And the 3 major scenarios in which it's used are shown here: equivocal serology or biopsy. In other words, the blood tests are sort of contradictory, or they're elevated, but the biopsy doesn't show celiac disease, or the other way around. So you don't have a sort of slam dunk diagnosis. A genetic test can be helpful, because if it's negative, then you've ruled out celiac disease. It's helpful when people who are already maintaining a gluten-free diet before getting tested for celiac disease want to figure out, could they have celiac disease? Because again, if it's negative, then it's not celiac disease. One's genes do not change. And so while the gluten-free diet can affect other testing parameters for celiac disease, it doesn't change the genetic markers. And finally, to assess family members, people who have a parent with celiac disease or sibling with celiac disease, will they ever develop it? Well, if you do a genetic test and they don't have that gene, then they will not develop it. Again, shown from that excerpt from that excellent review article is basically what you do with the genetic marker. If it's positive for DQ2 or DQ8, that means it's permissive for celiac disease. It doesn't mean you'll get celiac disease, but it means that it is possible. If it's negative, then we say it's extremely unlikely this person has or will ever develop celiac disease, and you don't have to go down the road of doing antibody testing, etc. And so that's the general approach. It's most helpful when it's negative, and if it's anything else, it's not informative. So that's basically how I impart, this information to our trainees, and how I have traditionally treated genetic test results. Useful if it's negative. But anyone who's had genetic testing for celiac disease and who's read the report realized that these reports give us more than just that. And actually, when it is anything but negative, you can see, shown here is what Prometheus reports. Category 1 is all the way at the bottom. That's when it's negative. We say it's extremely low, extremely unlikely. And then they actually say what the details are about whether you have DQ2, 1 copy, 2 copies. Homozygous means you got 2 copies. Heterozygous means you got 1 copy. And then all the way on the right, they talk about relative risk. I am not a fan of this characteristic. They say that they go from extremely low to extremely high. The reason I object to that is there's no genetic test that will give anyone an extremely high risk of celiac disease. They're talking about a relative risk. But ultimately, even someone with the highest risk of celiac disease, when they have based on this marker, most of them never develop celiac disease. So I take that interpretation with a grain of salt. I appreciate that this version of the Prometheus result is not in all capital letters. Sometimes we get it and it says extremely high in all capital letters, and it sounds even more sort of alarming. But multiple studies have shown that the specific gene type and dose matter. In other words, DQ2 probably confers more of a risk of celiac disease than DQ8, and the dose, the number of copies of DQ2 someone has, 2 copies versus 1 copy, that tends to matter. This is a study, a multi-center study, multi-country study, and on the x-axis is time. These are infants who were at risk for celiac disease, and they were tested sequentially over time. They were screened. And on the y-axis is whether they have celiac autoimmunity or not, which is not exactly the same as celiac disease, but close to it. People who stay all the way on top at 1, they don't have celiac disease. And over time, these curves separate. The group that has the highest risk of developing celiac disease, the ones who are going down, that's the DQ2 homozygous. They have 2 copies. But it's worth pointing out that that's the extremely high group in Prometheus. That extremely high group, 70% do not develop celiac disease during follow-up. So again, I wouldn't use the term extremely high. They do have a higher risk than others, but it's not an extremely high risk. Most people with those genes never develop celiac disease. And that brings me finally, just in the closing minutes, to a very recent study that came out that was an analysis of children with a family history of celiac disease, which may change the way we look at genetic test results. These were children who they were at risk for celiac disease. They were tested regularly with antibody levels, with serologies. And these investigators, what they did is they followed them and saw who developed celiac disease, and they developed a model looking at age, sex, number of relatives with celiac disease, and the specific HLA type, DQ2, DQ8, 1 copy, or both. And based on that group of children, they developed a risk calculator together with a recommended screening schedule. And so actually, they've published this screening schedule online, and shown here is a screenshot of it. And actually, if I have a moment, I'll actually show you how it would work. This is, it really is for healthcare professionals, but you can do this with your provider. They ask, what is the gender of the child, right? And you can click one of the 2 here, and they say, what's the risk group? And there you look at the fine print. What are the specific genetic test results someone had? So let's say someone is a male child, and they have a copy of DQ 2.5 and a 2.2. They're group 1. So you set that there. How many relatives do they have? Do they have 1 relative with celiac disease, just mom, or mom and a sister? So we'll say 2 or more. And how old is the child? Let's say the child is 2 years old. And you do that, and suddenly on the right, you see a graph, and you say, they say, this is what the cumulative incidence or risk of celiac disease will be, right? And this is a high-risk situation, right, with 2 relatives. And so they actually, you can follow, and they actually talk about the prediction. This is perhaps the highest risk category you can see, 32% chance of developing celiac disease by age 10. And they then give screening advice, and they say, based on that, we recommend you check in 6 months. And so this is like a really interesting concept, the idea of using study results to develop a risk calculator that you can then pay attention to a genetic test result, not just positive or negative, but actually look at what gene type and then decide, what is the risk and how should I screen? But there are limitations. They only looked at outcomes to age 10. It's not clear if risk continues to rise or if it plateaus. The risk calculator stops at age 8. They can't give advice beyond that age. And then this is like a bigger question. Should we even be screening? If the child is doing fantastically well and has no issues with growth, behavior, development at all, do we want to diagnose and treat celiac disease? And actually, even though you would think that the answer obviously is yes, studies haven't definitively proven that diagnosing someone who has 0 symptoms and is doing well will make them better off. So that's probably a topic for another time, but that's not settled. We wrote an editorial about this paper when it got published in a journal of gastroenterology, and we said that as a result of the risk calculator developed in this study, we can now use the details of our patient's HLA haplotype, the type of HLA gene, to develop a rational testing strategy and think beyond the dichotomy of positive or negative genetic testing in celiac disease. And so that, I would say, is sort of like the latest. It's the frontier of how we consider genetic test results. Whether this will truly be practice changing, I would probably defer that to my pediatric colleagues. I'm a adult gastroenterologist, and this fundamentally is a risk calculator for children. So maybe in the discussion section, we can hear from Dr. Verma. But I thank you for your attention, and I look forward to the discussion.
Thanks, Ben. We have a story about the study that Ben was just talking about, which caught my attention because it made me think that we tend to think of the value of genetic testing as only being able to give you a yes or no answer. And it seems to me that this kind of approach enables you to get more from that genetic test than just a simple yes and no. And so that's why I thought it was exciting. And we'll come back to this, I'm sure, in the question and answer. But right now, I would like to have Ritu show us a little bit, or tell us a little bit about the, and so in a certain way, we're talking about diagnosing celiac disease and how the genetic test can be used. And Ritu is going to talk about diagnosing celiac disease and the role that the biopsy plays in that. So Ritu, I'll let you now take it away.
Thank you, Amy. Thank you, Ben, for setting the stage here. I think, there's so much that we can talk about, but the theme is going to be, we have so much more to learn. And we really need to take each individual patient the way we need to have a common discussion with them. It's also been really an honor working with Ben with the SSCD and really moving forward the science of celiac disease and really getting the correct information out there. It's been a pleasure working with Beyond Celiac, and I also want to thank all the participants who actually sent some questions. So what I am going to try and do, if I can move my slides forward, I'm going to go out and come back again. But what I'm going to try and do is also answer some of the questions that were asked. Okay, this doesn't want to move. I will try and cover if I can get on with this. Let's see. Okay. I will go out totally. I'm going to go back to my emails and bring it back up. Sorry about that. Amy, if you want to do something else in the meantime.
Okay, sure. So Ben, I'll throw out one question for you while Ritu's figuring out the vagaries of technology, which gets all of us in a certain way. But so I switched to the bonus of questions. Someone had sent in the question that said that they've often heard about DQ2 and DQ8 genes that are related to celiac disease. And I'm not sure how many people get a really detailed report, how much of that information is always shared with them. But what this person wants to know is there more they should know about these genes and how they would influence the risk of their child developing celiac disease, their at-risk child of developing celiac disease. Is that information, so even as you demonstrated how the calculator works, is that information available to someone? How hard is it to become well enough acquainted with it to use it with the calculator, and also to understanding the situation that your child is genetically in?
So, thanks, Amy. So first of all, most people with celiac disease don't have genetic testing for it, simply because it's not part of the standard diagnosis and management. They don't need to know it. It's used in those sort of corner cases or the tough situations where there's, borderline results or someone's already on a gluten-free diet. If mom's got celiac disease and they're concerned about their children, unlike many conditions, hereditary conditions, cancers, where you want to test the person who has the condition first, we actually don't do that in celiac disease. I tell the parent, we know that you have the gene. The question is, does your child have the gene? So it is a little bit different that way. In terms of having access to results, 23andMe only tells you those small snippets and doesn't give you the full detail. And so to know it, it would require, going to one of the commercial laboratories. But once you have that, then the fine print will appear. So I hope that answers the question.
Mm-hmm.
And if you want,
like ready to go.
Yeah. Okay. So as I said, I'm going to try and cover some of the questions that were asked as well. So just bear with me. There was a question about gluten-related disorders and gluten sensitivity. So just as bringing up a background, these are the three conditions that most of us as patients and most of us as providers are sort of trying to sift through between celiac disease, wheat allergy, and the non-celiac gluten sensitivity. So the symptoms are could pretty much be the same in all three conditions. If you do the blood test for the antibodies, celiac disease traditionally is the only one that has the positive antibodies. If an endoscopy is done, the endoscopy for celiac disease is abnormal with the small bowel biopsies, while in wheat allergy and in non-celiac, traditionally the biopsies are normal. In celiac disease, of course, when you go on a gluten-free diet, you should see a response in terms of symptoms if you have the biopsy, the blood tests. And in wheat allergies, the testing is really more skin prick testing. You see an allergist to make that diagnosis. The non-celiac is sometimes controversial, but one of the things that's really important before people decide that they have celiac or non-celiac is if all your testing is negative, the blood test, the biopsies, and you have symptoms and they improve on a gluten-free diet, you've got to challenge yourself with gluten again to see, do you really have non-celiac or is it something else in the diet that's causing the symptoms? So what are the tests that are usually done? So these are the blood tests, or you might hear people talking about it as celiac serology. Those are sort of different terminologies that are used. So when we do the blood test, the first thing we're looking at is the total IgA level. It's an important number to look at because if someone has IgA deficiency, then the traditional blood tests are not helpful, and you sort of become in a different category of how you make a diagnosis. So that's a first test that we want to look at. And then there are different antibodies, and I'm not going to go into depth with those, but the ideal antibody that's done as a screening test is the tissue transglutaminase, or TTG. And then there are all these other tests, the deaminated and endomysial, that are done, which again can be a whole discussion on its own, but we'll talk a little bit more about the TTG later. So when do we decide to do these tests? Of course, if you have someone symptomatic and you think that there are symptoms that might be associated with celiac disease, before you go on a gluten-free diet, these blood tests should be done. And then we have high-risk families. So it's family members, people with type 1 diabetes, Down syndrome, and so on. those are used as a screening tool. And of course, as Ben was mentioning, those are things that we need to talk about, like when do you screen, how often do you screen, and so on. And if someone has a biopsy done, you could do this serology as more supportive for the diagnosis. And this is one of the tests that we do when someone has been on a gluten-free diet to monitor their dietary compliance. It has its pitfalls, but that's what we do for now. And then what's an endoscopy? So an endoscopy, again, in the scheme of procedures, a pretty benign test, though of course there is sedation that's used. It's not the same heavy duty sedation that you have if you're going in for a major surgery, but it truly is sedation. If you're a child, you go to sleep. If you're an adult, you're asleep, so you don't feel any of the discomfort. The preparation for an endoscopy really is nothing to eat or drink for a few hours. It's not a colonoscopy, it goes in from the mouth end. And the reason to do an endoscopy is to get biopsies from the small intestine. And you can see some inflammation in the stomach as well in celiac, but what we're looking for traditionally is biopsies from the small intestine. And very important that biopsies are done from many different sites, including the bulb. At one time, we didn't think the bulb was that important, but we do know now, and you should have at least 6 biopsies, 6 to 8 biopsies is what you're looking at. And an endoscopy is always thought to be the gold standard, but again, we're going to talk about it today. And we feel like when you're getting an endoscopy done, maybe there's more compliance or not, but a pretty safe sort of procedure, I would say, even in children, and definitely in adults. Ben can talk more about it, but it's pretty benign sort of procedure that happens, only 15, 20 minutes kind of thing. And then what happens? What do you see visually? So visually, often in children, it can look totally normal. So just a visual that's normal does not mean you've ruled out celiac disease. The biopsies are important. And sometimes you can see the scalloping and bumpiness and so on. That's a visual that you can see with an endoscopy. And this is what the biopsies look like. I know there was a question from the audience. What do you look at when you see the biopsy? So there's different levels. You'll see, again, we've all gone away maybe from the Marsh grade, but the two things from a general population standpoint that you want to know when you're reading your biopsies, you want to see an increase in the intraepithelial lymphocyte. That's one of the white cells that's seen, and you want to see some kind of villus atrophy. So there will be some damage to the lining of those villi. So on your left, or at least on my left, the screen on the top left, those are the beautiful finger-like villi that you see. Those are not seen in someone who has celiac disease traditionally. And there can be different levels of damage to the small intestine. So increase in intraepithelial lymphocyte and the villus damage is what one sees in the biopsies. And that's what the pathologist should see. And another question someone had is what else can give you these sort of changes besides celiac disease? You can see that with infections like Giardia. You can have it with other immunodeficiencies. There are certain medications that can also give you a similar sort of picture. So very important to really get a good history as you're analyzing these biopsies. So let's go to the question that we have is, should we or should we not be doing a biopsy? And why do we have this confusion? Why does Europe feel like they can go without a biopsy and North America says we should have a biopsy? So in 2012, there were European guidelines that came out, and they were very clear that if you have, as a person, as a patient, signs or symptoms that are suggestive of celiac disease. So very important to know that you can only follow these guidelines in 2012 if you had signs or symptoms that are suggestive of celiac disease. If you get a blood test done, the TTG should be more than 10 times the upper limit of normal. At another time, you do an endomysial antibody, and that should be positive. And you do the genetic testing, and it should be consistent with the HLA-DQ2 and DQ8 that Ben spoke about. In 2012, the European guidelines were if any of these criteria were not met, if a person was asymptomatic, negative HLA, and so on, then a biopsy was needed. And that was 2012. In 2016, NASPGHAN, which is the North American Society for Pediatric GI, Hepatology, and Nutrition, recommended that a biopsy should be done for everyone who has a suspicion for celiac disease. So you have symptoms that are suspicious or anything, you get a biopsy done. In 2020, the European guidelines got us a little bit even more confused and maybe made it a little bit more stringent, where this time the signs and symptoms you may or may not have, it was not discussed. So you don't necessarily need any of that. The TTG still needed to be greater than 10 times upper limit of normal, and the anti-endomysial antibody was positive in a second blood test. It was, again, the HLA was not necessary to make that diagnosis. So if you fell in this criteria with the TTG and the endomysial, you could go without a biopsy. And I think it has led us to feel a little uncomfortable in North America. And part of the reason is the TTG as a test there's no standardization here in this country for the available kits that are there. They're almost like 20 plus different manufacturers that come up with these different kits. So there's no standardization. And we also know that there's a variability in the way the TTG assay is performed. So you cannot look at a TTG from one lab to another lab and say, okay, I can go with that number. We also know that there are other conditions where the TTG could be falsely elevated. So children with chronic liver disease, almost 25% of them may have a positive TTG, but not really have celiac disease. Similarly, in children with eosinophilic esophagitis, which is a condition where you have allergy cells in your esophagus, may have TTG elevated. In inflammatory bowel disease and type 1 diabetes, you could have an elevated TTG. So us here in North America felt uncomfortable of making a diagnosis just based on a TTG. We also know that if there are children who are asymptomatic with other autoimmune diseases, and they can have a fluctuating TTG. So you could have a normal TTG, you can have an abnormal TTG, still eating a diet of containing gluten. So if you have these fluctuating TTGs, again, going with a TTG and just relying on that and going on a gluten-free diet, as you can imagine, would not be the right thing to do to go on a lifetime restriction. And then you have patients who are potential celiac, where you have a positive TTG and a negative biopsy. So again, in these children, what you find is if they are asymptomatic and you follow these children over time, and there was a study done looking at these children over time, over 10 years with potential celiac who are asymptomatic, less than 1/3 of those patients actually develop celiac disease. So again, most of us here in this country felt uncomfortable with just a TTG. And how helpful is a biopsy? So if you get a biopsy done, you of course are able to find out if there are any other associated conditions. There are some people who have celiac disease plus H. pylori plus eosinophilic esophagitis. So it gives you you are able to find if there's an associated diagnosis. We also know, at least currently, the majority of clinical trials, you need a biopsy done with that. And it's felt like if you have a biopsy done, you are going to be more compliant with going on a gluten-free diet and staying on a gluten-free diet, especially in pediatrics. I do believe that having the biopsy gets people to be more compliant if you think about teenagers. And we also know that the TTG by itself is not totally reliable in terms of a biomarker. We believe that if you have a biopsy done, then you have access to a celiac center. You're seeing a dietitian, you are actually getting the care that you need rather than just going on a gluten-free diet. So this is courtesy my daughter, Priyanka. I think a lot of you know that this is not me. So she made this for me last night. So thank you, Priyanka. But what I said to her, I wanted to bring this across that let's meet in the middle. I don't think one can follow just a biopsy and one can follow just no biopsy. So we really need to start thinking about meeting in the middle. So here's a proposed algorithm. And if everyone can follow that, I think that we could reach a stage where we would have some patients who don't really need a biopsy. So if you have classic symptoms, you have the classic symptoms with some malabsorption and so on, and you get a TTG done, which is greater than 10 times, and you have an endomysial that's positive, you could potentially consider this without a biopsy. Having said that, what I would like to add here is do not do this on your own. See someone, follow with a dietitian. If you have classic symptoms and your TTG is not that high, please proceed with an endoscopy. If your TTG is negative and you have a lot of symptoms, of course, you continue with the diagnosis and you might end up with a biopsy, but think about other things besides celiac disease. If someone does not have any symptoms, they have no symptoms at all, they're a sibling of another person with celiac disease, they have type 1 diabetes, any other autoimmune disease, and you have an elevated TTG, we don't think that this is the right time to call that celiac disease without getting an endoscopy or a biopsy. So the key here, if we want to get to a stage of no biopsy, have to have shared decision-making. So if your primary care person gets the blood test done, the TTG is elevated, don't start the gluten-free diet. As a patient, as a family, come across to a celiac center, meet your GI team, meet a dietitian, do the right thing, and you potentially may not need a biopsy at all. So thank you, and I will stop sharing.
Thank you, Ritu. I think we all learned quite a bit about the status of what's going on with the biopsy or no biopsy. One of the questions that we got it comes from a somewhat a group of people who feel, I think, often a little bit neglected, and that is the people who have dermatitis herpetiformis. And so can you talk a little bit about what the biopsy, how the biopsy in that condition is different? And the question that we got about that is that if the skin biopsy, which is the kind of biopsy that you'll describe, if there is one that confirms dermatitis herpetiformis, does it mean that they'll also have the intestinal damage of celiac disease?
So thank you. I think dermatitis herpetiformis, you really need to have a dermatologist who's thinking about celiac disease. If you have a dermatologist who is just going to do a biopsy or not a biopsy, it probably is not fair to the patient. So you need a dermatologist, and they have to stain for the IgA deposits, and they can make a diagnosis of celiac disease, or they make a diagnosis of dermatitis herpetiformis, which is related obviously to celiac disease. If you do an endoscopy, you may have almost 25% that the biopsies may be normal in an upper endoscopy. So hence you really need a dermatologist to work with you and get the right biopsies, and they can make a diagnosis. Ben, do you have any other experience with DH?
Yeah, I agree. You know, we call it celiac disease of the skin. It's, you know, a very close cousin. Not everyone with DH, though, ends up with celiac disease in the gut. I personally offer a biopsy of the intestine for people with DH after the diagnosis because it could offer another avenue of monitoring. You know, some people with DH, they may get better on the diet alone or with a medication, dapsone, but then are they strictly adherent and have they healed? So it's something one could consider. But you know, a skin biopsy for DH is, you know, that's a biopsy-proven diagnosis of a condition that's very closely related to celiac disease.
Mm-hmm, mm-hmm. So far, when we're talking about the biopsy, we're talking about it for diagnosis. But we did get a question from someone who wanted to know what role does the biopsy play in terms of monitoring celiac disease once you've been diagnosed? And if it is used, how often should it be used, and what kind of particulars would be involved in that?
So I think the guidelines are different for adults and pediatrics, and at least in pediatrics, there are no absolute guidelines. In fact, I think there's a trend now looking at, and there are more studies being done to look at and see, do you really get total healing or not in pediatrics? So there's a study done from Boston where they actually looked at children, but they had the biopsies done within a year or so after their diagnosis, and there was a high failure of healing. And so therefore the endoscopies have been recommended. I mean, I can tell you what I suggest for my patients is that if their symptoms are not improving, they are not growing that well, there's no other reason why they're having these symptoms, their antibodies are not improving, and it's 2-3 years from the time of diagnosis, then I do recommend an endoscopy and a biopsy. There is no guideline right now in pediatrics that every year or 2 years you need an endoscopy done. It really goes again with the individual child and family. And important, if there are symptoms, you look at all the other reasons why you can have symptoms besides celiac disease that you go through. And in adults, Ben, are you more inclined to do the endoscopies?
There's definitely more follow-up biopsy in adults, but guidelines remain vague about whether they should be done and how often. The most you'll find a guideline say is that they can be considered as a way to monitor celiac disease. There's no guideline that says you need to routinely do repeat biopsies. In my own practice, I offer one follow-up biopsy starting 2 years after the initial diagnosis. And I say 2 years because adults tend to take longer to heal, even when everything's going right and they're avoiding gluten successfully. It just takes longer for the healing process to happen. And if they've healed at that point, I don't continue to offer biopsies. I say this was the goal, and we don't continue to do this unless new symptoms develop. And so, the rationale for doing routine or repeat biopsy after the initial diagnosis is that some studies have shown that healing is a desirable endpoint. It's associated with a reduced risk of certain consequences of celiac disease. And so we aim for that. And because we can't always rely only on the symptoms or the blood work, it's another, or the dietitian's assessment, it's another way to monitor the patient. But if someone's feeling very well and their antibodies have normalized, and the dietitian believes they're doing what they need to do, I level with the patient and say, not everyone has a repeat biopsy, and we're uncertain if it's necessary in a case like that.
Thank you. So I'm going to shift away from the biopsy for a moment and ask a question that we got regarding genetic testing. If one of your children has celiac disease, but neither of the parents are known to have celiac disease, what are the testing recommendations that you would have for that child's sibling? So for your other children, you as parents don't have celiac disease, one of your children does. What do you do with your other children?
So I'll talk from a pediatric standpoint. I mean, the other children need to be screened for celiac disease. I'll hold off on the genetic testing for a second, but if you have a sibling who has celiac, then the other siblings need to be tested. Again, there's no firm guideline that it has to be every 2 years or 3 years. And I'll tell you what I do is I will suggest that the siblings get the serology, the blood test done, I say every year till they reach puberty, and then every few years unless they're symptomatic. And the reason I go every year till puberty is because, again, growth is a big thing for pediatrics. So if you miss that window, then you might, and a sibling has celiac disease, you might not achieve the growth. And the second reason I say year is it's easy to remember. So, if you said 2 years, 3 years, is it the 2-year mark? Is it a 3-year mark? So just to make sure that you don't miss someone from a growth standpoint who might have celiac disease as a family member, I suggest the yearly kind of thing. But that's not that it's the guideline for all of the societies, but it's something that I practice with that. And they also should be eating gluten. So, if they go off on a gluten-free diet, then, or they have limited gluten, then that blood test is not helpful.
Right. So another question that we have is someone wrote in to say that they have the genes for celiac disease, but their daughter does not, and they don't understand how this can be. And so they're asking why this would be.
So the heredity of the celiac genes can be complicated. So first of all, we get our celiac susceptibility genes, or HLA genes, from both parents. And so you can inherit all or your celiac risk just from one parent, or you can develop or inherit a celiac risk gene from both parents. Actually, if I share my screen, I can show you, again, from this wonderful review article, it's even possible, potentially, where neither parent has a celiac gene and yet the child does, because the way that these genes are passed down, you can inherit half of a susceptibility gene from a mother, half from a father, and those combine, and then you have a full copy of a susceptibility gene. So it's really, not easy to think about intuitively, but you can have a child that has DQ2 when the mother doesn't have it and the father doesn't have it, because of that phenomenon.
Mm-hmm, mm-hmm. Okay, and I think I'll take a moment now to see if our Beyond Celiac staff members who are monitoring questions, live questions coming from the audience, if there are any that they'd like to ask at this point.
I have one. Hi, this is Maria. Well, I'm not from me, but from an audience member wants to know the difference between DQ 2.2 and DQ 2.5, if that matters. And
so those are two celiac susceptibility genes. They're both compatible with getting celiac disease. DQ 2.5, people with that genetic marker are more likely to develop celiac disease than people with DQ 2.2. But it's the traditional way of thinking about it is both of those are compatible with celiac disease. You can also have a copy of both. You can have 2.5 and 2.2, or you could have 2.5 and 2.5. That's the highest risk, the so-called DQ 2.5 homozygous risk profile. And again, the thing about 2.2 is the one that is sometimes missed by certain commercial labs, particularly the at-home testing labs.
Mm-hmm. So I have a question that's a little bit different from some of the ones that we've asked about genetic testing, and that is whether having a certain type of celiac disease gene or combination of genes make it any more likely that symptoms will develop if a person on a gluten-free diet accidentally consumes gluten. So in other words, is there a connection between the kind of celiac disease genetic makeup that you have and how your celiac disease might play out when you're exposed to gluten accidentally, let's say?
It's a great question. I don't think we know the answer to that one. And that's a study that's waiting to be done, actually. It's a great idea. There have been a few small studies looking at whether the type of DQ2 that you have or the type of celiac susceptibility gene you have has any impact on severity. But those studies look at the, fortunately, very rare complication of refractory celiac disease. That seems to have a predilection for those with DQ 2.5, both copies. There have been even fewer studies looking at, how much villus atrophy the patient has or intestinal damage. The few studies that have been done seem to suggest that 2.5 and especially two copies of 2.5 are associated with those, more damage or refractory celiac disease. But in the same breath, I need to say the great majority of people with celiac disease never get refractory celiac disease. The great majority of people with 2.5, even two copies, never get refractory celiac disease. In fact, many never get celiac disease to begin with. So we think there's a little bit of a sort of dosage effect, but it's not a very strong effect as far as we can tell.
Mm-hmm. No, Ritu, if you wanted to weigh in on this at all?
No, I think it's a study to be done. Maybe Beyond Celiac will fund it. It's a very fascinating question in terms of looking at different genetic makeups, and is there an association with the villus atrophy? Is there an association with symptoms? Is it more that there is somebody with a particular genetic makeup that has a different kind of symptom in terms of neurological symptoms, or is it something? And it's really a fascinating thought process to look at.
Mm-hmm, mm-hmm. Yeah, these are the kind of questions that always remind us that as much as we've learned, particularly in the last decade, there's still a lot of things that we need to know. I think when one thing that I wanted to talk about a little bit, Ben, the study, the most recent study that you were talking about, and the calculator, or the risk predictor, is very specific to children who are at risk. And it does not apply and can't be used, or it hasn't been tested, so it's not as valuable for someone whose child just has symptoms of celiac disease, or they're thinking it might be celiac disease. It won't work as well, or it won't work for you. Just to point that out.
I think that's really important to point out. I'm glad you brought attention to that, Amy. I mean, in part, that was a matter of necessity. The investigators, the scientists who made this calculator, were using a source of patients who were already at risk for celiac disease by virtue of their family history. That's why they were enrolled in this study. That's why they were being screened so often. So you needed to have at least one close relative with celiac disease to qualify for that study. And so if a child does not have a close relative with celiac disease, these data do not apply, and that calculator should not be used.
So
And
I think
it goes back
go ahead.
into when we talk about biopsy or no biopsy. I think we all have to read all the guidelines and follow those, and then only, sort of look at the calculator, look at whether you do biopsies or not. That's symptomatic, the asymptomatic, the family member, it becomes an important piece as we go through the literature.
Right. I think that when you have celiac disease in a family, particularly a child, one of the things that you do all the time when you look at your other children is this constant question that you have. They don't feel so well. They don't seem to be as tall as I thought they would be. And it's always, is it celiac disease? Is it celiac disease? Is it celiac disease? So do you have best advice for parents who find themselves in that position? A, for their own sanity, and also what's the best way to deal with that kind of situation?
I think that it's so important to remember that their symptoms can be due to so many other reasons, and not to forget that, and not just keep focusing on celiac disease itself. I mean, it's important to focus on it, but not the only thing. And getting the blood test, if someone is eating gluten, is helpful if it's abnormal. And if it's normal and the child is symptomatic, then talk to your primary care doctor to see what else could give the symptoms. So just because your blood test is negative doesn't mean now you say, okay, fine, this is all in this child's head. That's not true. Then you really need to look at the child in terms of everything else. So having said that, I also think that because if one child has celiac disease and the other one complains of headaches, doesn't mean that that child has celiac disease. Treat that child just like an individual on their own. With that.
I tend to think that if you're in that situation, the thinking has always been that the genetic test might not be that valuable, because you're pretty much going to assume that they're going to have the celiac disease genes. But I guess one thing it could give you was a negative result that would then take that worry off your mind as well. I'm going to ask Maria, because we are running out of time, we have 3 more minutes, if there are any additional questions from the audience that she'd like to volley out there.
Yeah, that we had an onslaught of questions. I've been trying to answer you when I could in the chat, but someone had a really interesting one. So let's say you have the genes, or someone in your family have the genes. What would the role of epigenetics play on the development of celiac disease? Which may take up all of our time to answer. But
well, I mean, it's an interesting topic. It's understudied in celiac disease. Epigenetics refers to the way that modification of our DNA by small additional molecules, methyl groups and other groups of molecules, affect the expression of genes. And epigenetics may be the link between the genetic predisposition and the environment. Maybe something in the environment, including gluten intake and timing and quantity, or some other environmental exposure, might affect some genetic predisposition and affect the expression of those genes. That's very tantalizing. I think the HLA is more boring in that we sort of already know that the HLA is necessary because that's how gluten fits in a groove. The real question is, what are those other genetic, epigenetic, and environmental factors?
And Maria, do you want to ask one last question? We have 1 more minute.
Okay, so this came in and we see this a lot. So I've had the 2 blood tests, they were positive, I went off gluten. Do I need to have the biopsy? Why would I need to have a biopsy? And if, what are the benefits I would get out of that?
I think that is the big question. Do you do a biopsy or not a biopsy? I think if you have the blood tests that are abnormal, you've met with a gastroenterologist, you've met with a dietitian, you're doing the right thing, and the blood tests are improving and everything else is fine, then perhaps not. Or perhaps you want to get it done in a few years and make sure there's nothing going on. I mean, that's again a discussion you want to have with your gastroenterologist. But it's so important that if your blood tests were abnormal and you're now on a gluten-free diet, you make sure that you're following a gastroenterologist and a dietitian who know about celiac disease and who know how to counsel you in terms of what needs to be done, and to follow up blood tests, follow up all the things that you would need to do from a celiac standpoint. So don't necessarily need to have a biopsy, but I do strongly feel that you should follow someone in a gastroenterologist and a dietitian who are experts in celiac disease. I don't know, Ben, would you do anything different? Biopsy? No biopsy?
Agree. In a word, I agree with that approach.
So, and with that, I would like to thank both Ritu and Ben for joining us tonight. We've had an active and involved audience all along, which I think speaks to the importance that both questions about genetic testing and also the biopsy play in the lives of people who have celiac disease as they're trying to figure out what they need to do, what's important to do, what's the right thing to do, both for themselves and their children. So once again, thank you for joining us, everyone. I don't know, we do record all of the town halls and they are available. And Maria, I'm not quite sure how we handle getting that information out to people. You want to?
Yes, all of our town halls are recorded. They will be made available on our YouTube channel, and we will send an email to everyone who registered with a link to that as well.
Okay. And given that this was our first nighttime town hall, I think it went pretty well. And thanks again for our panelists and also for everyone who tuned in, and have a good rest of your evening.
Thank you.
Thank you.
So long, everyone.